Günaydın herkese.
Good morning, everyone. In this morning session, I will be speaking about the biopsychosocial approach and how important it is. We as psychiatrists know it very well. The social culture, the social texture should be considered while assessing the patient. It is also associated with the clinical presentation of the patient, which cannot be considered independently from the socio-cultural status of the patient. Our colleague, Dr. Mihriban Özgen, who has been working in Europe for a long time, will be speaking about transcultural psychiatry, integrating Eastern and Western perspectives in mental health. I would like to leave the floor to her straight away. Thank you. Good morning, everyone. You summarized very well. We'll be speaking about transcultural psychiatry. I will be speaking in English, which is a part of transcultural psychiatry, we can say.
For me to humanize the experiences of people in research, because I think sometimes we can get caught in the theory and abstract that we forget how to translate what we learn and know into practice. So for that reason, I formally introduce myself as the principal investigator and the psychiatrist in an institute that prioritizes the people of color, minorities, and make sure that we can diagnose and treat people with culturally informed modalities. And informally, I introduce myself to you, a Turkish psychiatrist who was born and raised here and who has the lineage of my grandmother, Mihriban Özgen, and her grandfathers, Ibrahim Özgen, which I dedicate this talk to them. So what I will describe here today is why do we do what we do as transcultural psychiatrists? What are the definitions of culture, transcultural, cultural psychiatry, the history of it? What is migration, cultural diversity, globalization, and why is it important? How culture affects the behavior? So my background is actually formally biological psychiatry. So I studied genetics in the US partly, mostly in Holland, and I was also traveling a lot. I've been to Kenya, India, Cuba, worked in different countries. But that was not the reason why I chose cultural psychiatry in my talk. While I was working in the Netherlands, I have met many patients, but 3 of them stuck with me and changed the course of my psychiatry vision, I would say. One of the patients I have seen, she was a 28-year-old Dutch female. She was from a gypsy community. She came to me with depression and anxiety. She had panic attacks. And at that time, my Dutch was also not so good, so I was thinking maybe I can't communicate really with her. But she taught me that it was not the language that connects people. It was really something else. With her, I started to think differently about psychiatry. My second patient, which was also making me ponder about these issues, was a 22-year-old Eritrean woman. She was pregnant 6 months from her raper when she was trying to escape from her country. She was suicidal because she didn't want to be pregnant. It was 6 months. It was a bit above the normal Dutch abortion period, so she was not allowed to have the baby out. So she was trying to poke the baby in her belly with anything that she can have in her hands. And for that girl, there was a committee formed in the hospital But then it was a domine, which is like a priest came. And which is nothing wrong with that, but I was there at that time as a assistant. Then I realized the communication barrier between the patient and the religion barrier. She felt not understood in her own culture. And then a few weeks later, I have seen another patient from another community, 16-year-old girl, pregnant. It was an incest relationship from her brother, and it was in a very closed church environment. So you might think that transcultural psychiatry was pulled to me from my migration background in the Netherlands, but it was actually really the Dutch patients that struck me. In such a small country, we can have such variation. And then I started to look more into transcultural psychiatry, started a residency in Almere. It is near Amsterdam, but it's very different than Amsterdam. It is a place where you can have, it's very multicultural. There I met a Turkish woman. She was 47 years old. She was from east part of Turkey. Her depression was not curable, they told me. So I started to talk with her. In my first session with her, it was like, there is something going on. She was hiding something. She wanted to tell it. And she kept telling me that it's so nice that she can speak in her own language with someone. In the second session, she was more open, and she said, I want to give you a secret, but it has to remain between us. I'm like, I explained her our rules of the secrets and all, but I was very open in her presentation. She said that her depression is because of her son. He was, I think, 17, 16 years old at the time, and he was using cannabis. So she was so depressed because it is, our culture is a shame culture, right? She can't tell it to her neighbors that her son is smoking cannabis. She was so ashamed, and she was also very afraid that the government or someone will take her child away if she tells it or if she shares it with someone. Of course, it's not going to happen just like that in Holland or in Europe, but this is a fear most of the migrants have when they live in another country. More paranoia, more fear. So I did something very unorthodox. I said, bring your son. I'm not a child psychiatrist, but bring him with you. Because she wasn't able to bring him to no one, no any other doctor. And then she started to bring him with her. I didn't treat him, but I talked with him. I talked with them together as a family. After a few months, she dropped her all medications, and she started to share her story. She's changed. Right now, she's working, and the son stopped smoking cannabis. He's entering the university stuff, and the whole family changed totally. I'm not saying that one thing changed it, but it's like having the open space and letting them tell their stories. That was, for me, the magic for her. Then I realized, even though I come from the biological background, there was one thing always missing in the therapy room, and it was the culture. Somehow, it is everywhere, culture is everywhere, but you realize that in our education, we sometimes really miss that part. And then I started to think of the terms, the biases we have, our interpretations, how we look at each other. And not only as a physician, but as a citizen, that I started to be more aware of it and talk more with my students in the lectures. What are our interpretations and reality from each other? Those questions I started to ask. Have you ever been the subject of a negative reaction based only on your membership in a group? It can be a Christian, it can be an Islam, it can be an LGBT, it can be a race membership. How about a positive reaction for the same reason? It can be a football club. Why do people have negative stereotypes about others? Why does it matter? And then in the terms of cultural sensitivity, which is the ability to be open, to learn about and accepting different cultural groups. When we talk about that, it sounds very easy. It sounds very like, yeah, right, this is so how it should be. But in practice, we see that it's not as it seems like. And we realize that each person is representative of a mixture of cultures. This can be a drug culture, it can be a single mother culture, it can be a victim of abuse culture, persons with mental health challenges, poverty, or being very rich, or being homeless, or jobless. Those are all subgroups in the cultures. By 2050, the US population is expected to increase by 50%. And the minority groups will make nearly half of the population. I know right now in Turkey, there's also many migration stream is going on. I think globally, it's happening everywhere. Some more, some less. And if we could shrink the Earth population in a village of 100 people, 61 will be Asian, 12 will be European, 14 will be from the Western Hemisphere. As you see, we have so much variation and diversity in ourselves. I'll translate that for you. In Holland, when you look at 2017, there have been around 4 million allochtonen. Wim, what is allochtonen? Migrants. In Netherlands, we are not using allochtonen anymore. Instead, we are saying that people with migration background. So Dutch population is 17 million. You can see the calculation there. And the non-Western are almost twice as more as the Western migrants. In the world, if you look, 70 million people are running, 70 million, and more than half of them are younger than 18. And those are not only numbers, they're people. How does it affect the child of having a traumatized parent? I work in the adult psychiatry, but it's not separable from the child psychiatry. Vice versa. Trauma and loss have a significant impact on refugees and their families. Because before a child's journey starts, her parents' journey starts already. And it's in 3 stages. It's pre-migration of the departure. So it can be, why do people migrate? Why do they go to other countries? There are social, political, or economical factors. There's a separation from family and friends. There are decisions regarding who leaves, who is left behind. There's act of leaving a familiar environment. There can be life-threatening circumstances or experiences of violence, loss of significance of others. And then there is the transit stage. In that stage, it can be long, short. It can be in a refugee camp, or it can be a safe journey. It can be in a detention center. There are so many struggles of waiting. People go to a foreign country and then they wait, and it makes them sick. There's immediate or final location of that relocation. And again, they can lose the loved ones during this transition period. And then finally, the last stage is the resettlement. Then there starts the cultural issues, being accustomed to a new culture, new country. There is very important the reception of the host country, opportunity structure of the host country. There are discrepancies of the expectations and what is there in the host country, and the reality. Degree of cumulative stress throughout the migration process here you see. And those are the patients that come to our polyclinic in this stage. And when they come to any country, I'm sure it's also happening in Turkey, those are all myths we have about the migrants. Are they taking over our country? Are they uneducated? Are they stealing our jobs? Are they uncultured? They are not to be trusted. Those are all myths. When you look at the health disparities, it is huge. And there's a growing evidence that these disparities are a function of immigration, cultural difference, and racial discrimination. So what happens with the culture and mental health? There is a big impact of culture on psychiatry, as you can imagine. There is immigrant and refugee mental health, and I will come back to that in a bit. It's idioms of stress. We're talking about cultural considerations. There's global mental health issues, there's trauma, political violence, and then cultural formulation, how to detect this. What is culture, anyway? It's shared learned behavior and meanings socially transferred in various life activity settings. So culture can be transitionary, situational events. Right now we are here having a culture. We're talking about culture. Now we are creating a subculture here. It can be relatively enduring into ethnocultural lifestyles. But in all instances, culture is dynamic. It's subject to change and modification. It can be presented internally, such as values, beliefs, attitudes, orientations, consciousness levels, perceptions. It can also be externally, roles, institutions, social structures. It shapes and constructs our realities, which is our, again, perceptions and orientations. The definitive feature of a minority group is that its members systematically experience lesser income, authority, and power than other members of their society. A minority group is not necessarily a smaller portion of the population than other groups. Think about 1% of the rich. Who is minority then? And we have this polite racism remarks as well. Those are fixed ideas. For example, Asians are cold and calculating. Turkish men are narcissists or antisocial. Chinese are bad drivers, such as. And this is in the polyclinic, we have to deal day to day. I hear from my patients that they're also unfortunately categorized in these wrong fixed ideas. There is, again, the culture of the role of culture in psychiatry to work with these issues with the people, because culture and psychopathology are inseparable. And there are, this, in that sense, two perspectives: cultural relativism, and then there is the universality argument, which I will illustrate in a table, easier to grasp than the theory. A short overview about the psychiatry, how it arose in the post-enlightenment of Europe about 200, 300 years ago. There were two main sources. First, the need to control and put away so-called lunatics, which were disturbing the society, to create a social order. And the second reason was a growing interest in matters to do with the mind in European medical circles. Here you can see how it started from 1418 to 83. So what does cultural psychiatry do in that sense? It's a branch of psychiatry which is concerned with the cultural and ethnic context of mental disorders. When I tell about cultural psychiatry in Europe, I always say that it's really not about migrants and refugees only. Culture is everywhere. It's about the person in the context. And we work closely with anthropologists. So we discuss a lot about the descriptions, definitions, assessment, management of the psychiatric conditions, while using concepts and instruments from social and biological sciences, which to have advantage of a full understanding of psychopathology and its treatment. So here again, this is the nice illustration of extreme relativism and extreme universalism. So universalists say that mental disorders are essentially the same throughout the world. And in relative way of looking is, one is crazy in relation to a given society, and both can be right actually. So it's like the two polar ends, and I believe we are really somewhere in between. And that's why it's very important to consider someone with its own context to understand that. So in general, non-Western, Eastern traditions of mental health, some people compare it. In Eastern, we are more harmony with other people. We are group people. In West, there is more individualistic looking way of life. In Eastern, relationships are very important. In the West, it's personal autonomy. And correct me guys if it's changed in Turkey in the recent years, because I wasn't here in like 15 years. In the East, there's a keep of outer world constantly, so there is a conformity with society. And in the West, it's more like keeping inner world constant, control altered state of consciousness, for example. In the East, there is the freedom of inner experience, variation of the inner experience. And in the West, it's more freedom of expression, variety in behavior. And again, world is changing and everything is so dynamic. This is something maybe much valid from the past years, but I believe it's also changing. And I think it's now we are really blending this two. So culture is really relevant to psychiatry again. And for example, scientific issues. That's how culture influences the brain and behavior you can work. Social issues are who are belonging to some certain racial categories or class may be at significant disadvantage in terms of access to health. For example, that patient I had from the gypsy community, she was not allowed to go to a dentist. So she came to me when she was 27 with all her teeth decayed because she was not allowed to go. That's why it's also important to understand the social issues and the context of the patient. There are clinical issues, and it's the accuracy and effectiveness in healthcare delivery. Ethical issues are important here, because we as clinicians may have an idea of what is healthy for the patient, but they might not agree necessarily. It can be blood transfusions, it can be another issue. Now we are talking like COVID vaccinations. And then transcultural psychiatry looks also about the human rights, because culture is essential as water, as air to us, and no human being can be without their culture. So we need the culture to nourish and flourish. So everyone has a right to their culture. There are challenges of this multiculturalism in mental health care. And the current situation, for example, with immigrants is the underutilization of the services. There's high levels of discontinuity. We have lots of no-shows, we call it. Patients cancel on the appointments. There's poor adherence. Sometimes most of the time due to this, poor results. There are misdiagnoses. I have had to correct so many schizophrenia diagnoses and bipolar diagnoses in Turkish culture in Europe, because I'll give you an example. Once a colleague of mine has called me and like, I have a bipolar patient, but I don't understand him really well. Can you see him? Okay, why do you think he's bipolar? Because he spent 10,000, at that time, 10,000 euro in a wedding when he didn't have money. So for us, from Turkish culture, this is very normal. We spend money for our children's wedding, even if it's going to cost us to loan from others. But for a Western point of view, this is like a manic way of behavior. But it's, again, when I say West, it's also the person there. It's not, I cannot generalize it to the culture. But that was one of the examples. And the other example, of course, I have lots of jinn stories. In my polyclinic, I hear it almost daily that my patients tell some things about jinn, but they have been diagnosed with schizophrenia from others. It is very interesting to tackle these issues in that context. I think it also has to do with the background of the person who they are coming from. They have also difficulties entering into the system. Some of the times, migrants don't know where to go if they want to go to a specialist or even a house doctor. House doctor is like Christian Hekim. And then they have difficulty in understanding the culture and the language and the social support. Another barrier to access is the stigma. They're afraid to go to a psychiatrist. I give that example as well, that one of my patients met someone that she knows in the waiting room, and then told that she was there for cleaning job. She was afraid to tell that, or ashamed to tell that she was a psychiatric patient. So there's a big stigma still. I don't know in Turkey if it's still like stigmatized to go to a psychiatrist.
Not as much so.
Not as much? Great. There's a relay on the family support. That's also problematic. Like first generation doesn't speak the language very well, so they bring their children to the doctor to do the translations. So it is also a big issue. It's not something that should be put on a child to translate the parents' psychiatric problems with the doctor. And in our communication, we also see that there are lots of concerns about the side effects of the medications. There's a big stigma if a person has an anti-psychiatric medication that she will have cancer or something. So still those myths are going on. There are geographical difficult access. Sometimes they live in another part of the country. They find it very difficult to find the hospital to come. And then we have long waiting lists. There are cultural bond syndromes. Those are very interesting things. In the DSM-5, you can find them. I also have some videos. If anyone interested, just email me. I can send them to you. I put them here in the slide, but it will be difficult, I guess, to play it right now. Those are, aberrant behaviors in some cultures when we call it in Turkish like tikler. But those are like very aberrational movements, and you need to watch the videos to understand what I'm talking about. It's like someone all of a sudden laying down on the floor, and for them it's something cultural, but if you're as a psychiatrist looking at it, you can diagnose it with hysteria, but it's not necessarily hysteria. For example, in Amak from Malaysia, it's an episode of sudden mass assault against people or objects, usually by a single individual following a period of brooding that has traditionally been regarded as occurring in that culture, but is now also increasingly viewed as a psychopathological behavior, so it can also be the other way around. And then we have idioms of distress. For example, a grandma saying that my nerves are bothering me doesn't mean that necessarily she has a neurological disorder. Or depression. We are using it a lot. I hear it from my child even like, Mom, I'm depressed today. Like, it doesn't necessarily mean that the person is depressed, of course. Or a burnout. Another cultural idiom is burning the dinner if a person is angry to the husband. Those are the examples, melata. If you would like to Google and YouTube, you will see those culturally bound expressions. Very interesting to watch this. And the somatization. Because we don't have really, some cultures don't have the terms of depression or anxiety. So, but I hear it's like, I have a headache. And it's mostly like they want to say that they have depression. So we're trying to sculpt an idiom as an actual biological syndrome can be misleading. Can an idiom also be a symptom or vice versa? Can there be bodily gestures of distress? There are. That's why it's really worthwhile to look at it to understand, because it's not a lot of them. If you know at least 10 of them, I think you can really grasp the culture of using the bodily items of distress. Just another video I wanted to show it to you. I'll give you the YouTube link here. And it's talking about, sorry, what would you name depression if the term doesn't exist in your culture? Here, later on, it's a pity that we can't have the video right now, but here you see that actually, yes, it's universal. Depression exists also in Africa, also in Malaysia or Turkey, but the way of expressing is different. And you don't need to be Turkish or African to diagnose it. It just takes the empathy and the openness to want to hear what they are going to say. So how do we bring these cultural considerations into our clinical practice? What must the clinician know, actually, in order to diagnose and treat the patient? Language, I don't agree so much. I don't think language is the most important diagnostic factor. I work day to day with the translators to different cultures, from Africa or Saudi Arabia, in Arabic or in Farsi or other languages. And it's not that big of a barrier. It is important, though. Religion, again, I see it as the language. You don't need to be the same religion of a person as a psychiatrist to diagnose or treat the patient. Traditions, beliefs, ethnics, gender orientation, the same. It comes all back to empathy and openness and willing to understand and listen to the story of the patient. So knowledge is cultural and social aspects, concept of the problem, trying to explain them how to find help, trying to understand their living conditions, and the aspects related to immigration, those 3 stages I showed you. If a person has a grasp of that, it can help enormously to the patient. To explain and understand the explanatory models. What is meaning? What is context? And idioms of distress and notions of ethnopharmacology is also important. There I can give you another example. What I realized that different culture patients react different to the antidepressants that I'm prescribing. Sometimes the side effects are different, sometimes the doses, and if it comes to sertraline, which we use a lot, I always go very low doses than my Western patients, because I don't know if it's placebo, but in a very, very, very low dose, which shouldn't work actually. Next week, when I have a phone call with my patient, they are like, yeah, thanks doctor, it helped me perfect in 1 week. So that's, I think, also the cultural way of working of it. And then what is normal? What's abnormal? It's all relative terms, of course. And the cross-cultural investigator must have an intimate understanding of the normal range within the cultural pattern, which helps to develop a standard of normality with the reference to the culture itself. I think if we grasp those terms, it's not only for psychiatry or our patients, but our day-to-day basis, we understand each other within the context of our cultures. In that sense, abnormality is also, you could put them into the similar categories as normality, very relative terms. So again, to what can complicate this diagnosis in our patient group, there is the diagnostic system. Yesterday I was talking about that for PTSD. Most of the diagnostic systems are based on the majority of the Western population. So there, I think we should really be aware of, for example, race trauma for PTSD. Is now people are getting more aware of it. I think we should always keep it in our background. If a person is showing different symptoms, it's not necessarily that they don't have PTSD, for example. It's just like their symptomatology is different than what we are used to see. Idioms of stress can help there, and the systems presented by the patient sometimes doesn't really fit well with the Western diagnostic system. Their explanatory models help a lot. There are cultural perceptions of cause, stressors, and support. As you know, stress, money, or family. And family is very relative in different cultures, East versus West. How would you describe your problem? Resources, social support, and resilience. Spirituality plays a role as well here. And role of cultural identity is also the mixture of all those. It can be ethnicity, it can be faith, migration-related problems, and homelessness as a culture. And when you look at all those separations, they can have all these multiple identities in it. When it comes to intercultural communication, I could summarize as it's like listening and speaking skills, interpretation of the cultural codes. Respect is very important for especially the patient groups that we work coming from the Eastern cultures. Awareness of the presence of prejudice. Adapting to the style of the patient. It's about the distance. It's about the mimics. Create a comfortable space given the patient's needs. I had a patient once from Morocco, and he never looked at my face. First I was like, okay, is it autism? You might think. But he thought it's a sin to look at a woman's face. So those are all about like to understanding their culture and interpret with that context. Impact of culture on psychodynamics is also similar: dependency versus autonomy, linguistic competence, cognitive style, social support system, material culture, and psychological sophistication. We know that there's an impact of culture on major psychiatric disorders. For schizophrenia, there are now different views on that. It used to be believed that it goes more with migration, but I'm not convinced yet for the science of it. Depressive disorder, it is convincing. Anxiety disorder, somatoform and dissociative disorders. I like this parable a lot. It's a monkey and a fish. They were caught in a terrible flood, and they were being swept downstream amidst torrents of water and debris. The monkey spied a branch from an overhanging tree and pulled himself to safety from the swirling water. Then he wanted to help to his friend, the fish. So he reached into the water and pulled the fish from the water onto the branch. So the moral of the story is, good intentions are not enough. If you want to help the fish, you must understand its nature. Thank you.
Teşekkürler, bu harika sunum.
Thank you very much for this wonderful presentation. I believe you have provided great insights for many of us. And Turkey is becoming a multicultural country day by day. Especially we have migrants in Istanbul and in provinces like Gaziantep in the southeastern part of the country. So we have more and more migrants that have different cultures, and those people had to flee their countries because of various reasons. And I believe it has been really fruitful for all of us. Thank you very much. If you have any comments or questions, we can take them now.
Thank you, Haval. That was a very interesting lecture and very thought-provoking. One of the issues that you touched on is the education of the psychiatrist or the physician. It's a difficult problem in a background in any country where people own their own prejudices that may not be aware of them. Implicit bias, implicit racism, implicit discrimination. what can we do
Yeah.
to elevate the mind of the healer to transcend this problem?
Excellent. Thank you, Andy, for this question. Yesterday, I was describing privilege, and privilege is blinding. When we are privileged, we're blind to the others, and it can be regardless of our education sometimes, unfortunately. I think everyone is educatable, but we carry our prejudices. You're asking it in the clinician's point of view, I guess. True. I think what helps is to start a dialogue on that. And this is what we are now starting to do with this whole debate about this diversity and inclusion. This debate started, and then people realized, for example, for diversity now, it's not only for that it's because it's ethical to have a diverse population. Sometimes because people bring a woman from somewhere and then two migrants and like, okay, we are diverse, but it's not about it, guys. It's like about to understand really why these people are there. It's like you can invite someone to a birthday party, but you also need to ask her to dance. To inviting her is diversity, and to inviting her to dance with you is inclusion. I think here we need to look at inclusion and equity. And the other point is, I think we should understand the terms. When you talk about like diversity, it's not really wired in our brain. Our brain, our primal brain, doesn't want to see something different than us. We are more comfortable with the people that are like us. This is our primal code. It's not our prefrontal cortex. But when we talk about equity, our ancestors in the hot bushes, they always knew what is unfair. So equity is touching us. That's why I think we should more talk about equity than the diversity. If we understand those terms and spread that, I think that dialogue will start to make the revolution of understanding how we could live in that harmony and understand other culture. İki video gelmiş, açalım mı yoksa size bırakıyorum moderatör olarak?
We have two videos. I provided the links in the slides, so we have them right now. They are ready. If you want, we can watch them now. There's a question over there.
Your presentation is great presentation. I worked for 11 years in Switzerland at the University of Basel and in cultural psychiatry. I think so. One of the biggest issues in psychiatry is that the psychiatric disorders or diagnostic systems are not valid itself. We are discussing the validity of schizophrenia or depression or anxiety. I think so. In terms of cultural issues, the psychiatry is more and more experience independence. A part of psychiatric diagnostic systems are experience dependent. That means in PTSD, if you have to diagnose someone with PTSD, you have a list of symptoms, but they have to be associated with an experience, past experience of the patient. So, traumatic experience, that means so an episodic memory. But the rest of the diagnoses are experience independent. We have only a list of symptoms. Let's say so delusions. The definition of delusion is that a false belief that is not amenable in the light of conflicting evidence. If we define a state, mental state, is a false belief, then we have many problems in terms of cultural issues. This is also in OCD, so anorexia, so eating disorder. If we have an experience, then the cultural accuracy is also the understanding of the culture is much easier. And we have to discuss the psychiatry of being so more so experience dependent, because the experience itself of the patients, the specific experience, gives us more information. It's not easy to understand the whole culture of the patient in order to understand him and to help him.
Yeah.
So I'm very interested
Yes.
about your ideas.
Thank you so much. Thank you all for this excellent edition that you're and sharing your experience with us. This is very interesting. Yeah, that's true. I could give you an example like that. You can have a 16-year-old in your room, and that person is, she doesn't want to communicate with other people. She's very timid. She doesn't have many friends. She's socially awkward. And she is, sorry, I want to say 36, not 60, 36 years old. And she lives together with her parents. 36-year-old, living with her parents, not having many friends. So you want to know then what is her cultural background, because it makes a big difference. If this is a Turkish person, 36-year-old, living with her parents, it's kind of okay, I think, still in Turkey, no? But if it's a European 36-year-old woman living with her parents, then you might think like, okay, there's something not right here. But if you also hear that this 36-year-old, okay, she's Chinese, she lives in Canada, and her parents migrated, you can think like, okay, that can explain it. But if her parents are also concerned about that person, then again you have the dilemma, then it's not their culture. So in that sense, it is, you're right, you can't say that it's all culture, but it's really understanding their story. What is the background? What is happening in the family? That's why I suggest that always have the whole family in the room, even if they cannot come. When I have patients like that, I call their family in Ethiopia or wherever they are, just to have that presence of them, to understand what's going on in the family, really. What type of person they will describe their child, their 36-year-old child. What is it like for them as parents, or as sister, brother? And sometimes I have patients, they lost the whole family in the war. Then I say, okay, then bring your friends. I have no friends. Okay, then what we do, let's draw. Tell me, how was your father like for you? How was your best friend like in Syria? So really inviting them, even if they are not physically there or cannot be there, still in a paper to drawing. It comes all back to their stories, how important their stories are, to understand and being open to listen the whole story of them. Then we can put them in the context, and that helps with diagnostic and also treatment. Thank you for the excellent question.
Başka soru var mı acaba?
Any other question? I wonder about your experiences, because I know there is migration in Turkey, and I hear lots of complicated stories. And how do you evaluate this? Because you may be seeing many different types of patients, migrants, I believe. As far as I know, there are many Syrians, Syrian migrants in Turkey. What do you think about this? What is your perspective about their diagnosis, about their treatments, and do you face any challenges in diagnosing and treating those patients? Even in Istanbul, I can tell you that we have lots of Syrians living with us for many years. We have, unfortunately, the language barrier. It is difficult to find a translator, and we have to trust in the relatives of the patients for communication. And of course, there is the ethical side of it, and also the confidentiality side of it. And I am working at a hospital, and we have a translator that speaks Arabic, for instance, but still we have this language problem going on. And when you have a language barrier, it is not easy to have a full psychiatric assessment. And there could be a child, for instance, the mother comes with her son at the age of 13, and you expect the child, the son, to translate for you because the patient doesn't have any other chance. She is there with you, and you don't have a translator, or she doesn't have a translator. This is why the child has to translate, and this is the main problem, the primary problem we face. This is my experience, and I wonder something. Psychiatry is an area that is highly sensitive to culture. We should be very careful about it. And during the education at the medical school, do you have a special curriculum for this in the Netherlands, or do the physicians learn all these cultural aspects during their profession? There are psychiatric associations in the Netherlands, Biological Psychiatry Association or Genetics Association, etc. And also we have Sociocultural Psychiatry Association. I'm working for the board of this association, and until now we had this in our curriculum. It was included in the training, but unfortunately it was removed last year. And this is a dilemma for Europe too, because we are talking about culture more and more, and the world is globalizing, but on the other hand, the culture is changing. And yet there is still the resistance in psychiatry. We don't want to hear about culture. It's something that should be feared of. But without culture, how can you understand psychiatry? And while speaking about the culture, it looks like you are talking about social psychiatry. Therefore, although my background is on genetics, now the world is moving towards the culture, because when we look at the genetic diseases, autism or schizophrenia, they all overlap. So we cannot reach somewhere. Therefore, when you understand the culture, you can diagnose, you can treat the patient. And during the training of psychiatry, this is something that should be paid attention to. And also it helps you question your ability to empathize. And when you have this privilege, you are blinded by it. And you may have been born into a rich family, and you may not understand what poor go through. And it's the same for the training. Therefore, during the psychiatry training or medical training, the empathy should be one of the subjects that should be trained. And it is really interesting that this was removed from the curriculum. Unfortunately, this is the case.
So forgive me because this might be a simplistic or naive question, but as I'm listening to the conversation, I'm thinking about the transcultural piece, at the macro level, it's between different cultures that relate to different nations or religions. But when you think about transference issues in psychiatry, and you think about, say, difficult patient areas, I'm thinking particularly about trauma-informed care and people with personality disorders. For psychiatrists who are relatively healthy, some psychiatrists find those patients very difficult. And one could see that as a form of discrimination based on culture, but it's a microculture,
Yes.
not quite as big. So I'm wondering what you think about the whole notion of this just being an extension of problems with transference that psychiatrists have with patients.
Yeah. If I understand it correct me if I'm wrong, but you're saying that there is in the macro level this discrimination that, it's very clear, but there's also the subcultures that even a physician can be discriminating against. It can be personality disorder for a healthy psychiatrist. Is it right? Exactly. No. Exactly. And actually transcultural psychiatry is also, that's very good what you're saying. Because when you look at it, transcultural psychiatry starts in the room of the doctor regardless, because there's also a cultural difference there. One is the psychiatrist, the other is the patient. So that difference is always there. But when you think about the specializations, what I witnessed is, for example, for addiction, there is a big resistance for at least my group of psychiatrists that, I don't want to treat a patient with addiction, for example. And there you see the discrimination towards the subculture that exists. Again, I think they're all similar, whether it's race or ethnicity or gender identity, orientation. It all comes to having the dialogue and willing to understand what's going on for other person, without that blinding of ourselves to our privileges. I think it comes back to human. Yeah. It is a much bigger problem than we think it is. And it's so interesting that it's happening in psychiatry, because psychiatry is the place where actually you want to understand the human being, where you want to have the empathy. Why would someone be a psychiatrist? Eric.
Thank you very much, Evo, and this is a great discussion. Now, you just referred to some things that you encounter in your clinical practice in the Netherlands, right? So my question is maybe based on your personal history and your personal experiences. How do you feel that you can overcome these barriers where these notions about the importance of diversity and incorporating cultural backgrounds is integrated into a very Western model of psychiatry in like where you work? Mm-hmm. And how could we overcome like residents and novel people that sort of need to incorporate, or should they need to incorporate these practices? Because in my experience, sometimes it is iffy. It requires more time, it is odd, it requires a different way of problem solving, incorporating more people into the therapy room. What are your personal experiences of that, and how can we learn from there?
Yeah, thank you, Eric. I think you know Turkish, because we were just discussing that in Turkish here. It's very nice. Yeah, we have, okay, to educate each other.
Birbirimizi eğitmemiz gerekiyor ve bunu tabii ki müfredatımıza da dahil etmemiz gerekiyor. Çünkü şu ana kadar, yakın zamana kadar bizim en azından kültürel psikiyatri diye bir bölümümüz vardı müfredatta. Artık bu müfredattan çıkarıldı maalesef ki. Ama bu tür metotlar, yöntemler bir şekilde evet uygulanabilir ama psikiyatri eğitimine, müfredatına dahil edilmesi gerekiyor. Benim kişisel görüşüm şöyle. Ben Türkiye'de yaşarken şöyle düşünüyordum. Saat 8'de hasta gelmeliyse 8'de gelmeli. Ama Hollanda'da mesela çalışıyorum. Afrikalı bir hasta saat 10'da geliyor. İlk haftamda dedim ki nasıl olabilir böyle bir şey? Ama ikinci haftada tamam dedim, bir şeyler var demek ki. Onun kültürüyle alakalı bu. Ve şimdi hep 2 saat öncesine göre ayarlayarak veriyorum randevuları ve bazen de geliyor ve bekliyor. Mesela saat 3'te veriyorum randevuyu ama saat 1'de geliyor. Mesela orada oturup beklemeyi seviyor. Orada bekliyor hasta. Şimdi kültürü bilmiyorsanız o zaman bu kişiye yanlış tanı koyabilirsiniz. Onların hikayelerini dinlemeniz gerekiyor. Neden buradasınız diye soruyorum. Onları dinlediğimi göstermeye çalışıyorum. Onlara saygı gösterdiğimi böyle gösteriyorum. Ve bu saygıyı gösterdiğim zaman hasta dinlenildiğini düşünüyor. Diyorum ki artık size antidepresan vermeme gerek yok. Çünkü bu histen sonra zaten kendini daha iyi hissediyor. Mesela Afrika'dan gelen bir hastam var ve sokaklarda yaşıyor. Bir sığınak var ama e, bana geliyor. Yaşadığı bir sığınak var ve geliyor ve onu araştırma günlerimde alıyorum. Geliyor, oturuyor ve seanslar esnasında da uyuyup kalabiliyor. Neden? Çünkü orada kendini güvende hissediyor ve kendini güvende hissettiği tek yer orası. Ve yine burada insanları anlamaya geliyor iş. Bunu açık bir şekilde konuşmaya geliyor. Ve diğer departmanlara da eğitim vermek gerekiyor. Belki mesela bağımlılık departmanı olabilir. Böyle bir hasta gelip de böyle bir şey yaparsa şaşırmayın, korkmayın. Bunun aslında altında yatan şey şu, anlamı bu diye onlara bu anlamda yardım etmemiz gerekiyor ki böylelikle her şey bağlama oturabilsin.
Bir soru daha var galiba.
Maybe one additional one that was on.
Dilimin ucundaydı. Bir şey daha söyleyeyim müsaadenizle. Sizin bir kadın psikiyatr olarak bu kültürel bakış açısıyla rolünüz nedir, ne olmalıdır? Ve belki de genellikle erkek hakimiyeti olabiliyor pek çok ülkede psikiyatri alanında. Acaba sizin oradaki rolünüz nasıl algılanıyor? Bunu merak ediyorum. Ben tıp fakültesinden mezun olduğumda Türkiye'de çok kadın erkek arasında ciddi bir fark yoktu. Hasta hangi doktoru buluyorsa ona gidiyordu. Benim için çok değişmedi. Ama Hollanda'da genellikle yalnızca kadın psikiyatra gitmek isteyen hastalar olabiliyor. Onlar bana sevk edilebiliyor. Genellikle kadınlar bir şekilde mağdur olan kadınlar geliyor. Ve bu açıdan da onların talebini memnuniyetle karşılıyorum. Çünkü o kendilerini böylelikle farklı hissediyorlar. Sadece kadınlar değil tabii bu erkekler de olabiliyor. Bazen erkekler de kadın psikiyatra gitmek istiyor. Mesela Orta Doğu'dan gelenler ve bir şekilde yine hastanın neden böyle bir taleple geldiğini anlamak gerekiyor ve o fikre saygı duymak gerekiyor.
Başka soru, yorum, katkı yoksa? Herhalde o kadar. Peki. Çok teşekkür ederiz katılımınız için ve çok teşekkürler tekrar.
Ben teşekkür
Bu harika
ederim.
sunumunuz için. Sağ
Ben
olun.
teşekkür ederim. Benim için büyük bir zevk.
Teşekkürler.